So building off of what we were just talking about, why do we do this? Let's take a moment and ask ourselves this question. Well, DR and CR is the most frequently used modality, right? You may look at, a radiologist may look at, or a hospital may have, 100 CT scans a day, or I don't know, a couple hundred MR, depending on how many scanners they have. But they're going to look at easily many hundred, maybe 1,000 X-rays, just plain our radiographic imaging. So it is the most frequently used imaging modality throughout the entire world. And luckily, it's one of the lowest radiation dose modalities. So the question is, wait a minute, if it's a low dose radiation modality, why are we worrying so much? It's the idea that we use it so often that even if it's just a small amount of radiation, it adds up to the whole population. And so when you look at making some changes, if you make a change to, say, CT, which is a high dose protocol modality, that's going to make a big impact, but it's actually only affecting a very small percentage of your population. Now, if you make a small change in DRCR, now once again, that's a small number, so it's a small change, but it's making a big impact to a large group of people. So when you just look at it kind of in a mathematical way, even though it's a low dose protocol, or modality, it still makes a very big difference when you talk about the whole population of, say, Thailand or the US when it comes to medical dose. The other reason is oftentimes, DR, CR imaging, it's of course it's two-dimensional, right? So it's all of our anatomy compressed into one plane. And so it can be hard at times to read through that. If you're looking at the lungs, well, you're looking through ribs, you're looking through mediastinum for the heart, you're looking through the scapula, you're looking through all this anatomy that's compressed into one image. And if the dose is not quite right, if it's a little too low, it's going to be extra noisy. So I'll have all the anatomical information all in one, and then it's being covered up by noise. And so the point here is they're already difficult enough to read. We got to make sure that there's as good a quality as possible so the radiologists are comfortable getting their diagnostic or doing their diagnosis. And the second reason is we don't do, well, let me step back. Film imaging in radiography is mostly gone away. I would assume that in most hospitals, and probably in Thailand, I can speak for the US, there are basically no hospitals that use film here in the US. So there may be a few in Thailand, I don't know. But for the most part, those days are gone. And digital imaging masks poorly optimized dosimetry. In other words, you can get a fairly good image. It must be the next slide. I'll have some images in the next one I'll show you. But for the most part, if you overexpose a patient by 2 times or maybe even 3 times the dose, the image will still look the same. If you underexpose the patient by a little bit, the image will be a little grainy, but for the most part, it'll be okay. So digital imaging is actually fairly forgiving, and that's because the digital detectors have a linear response. And so given the ability for anyone to use their mouse to window and level, they're able to overcome some of these inherent deficiencies that they're seeing. And so image quality in digital images do not correlate with patient exposure. So if the image looks really good, it might be properly exposed or incredibly overexposed. You really don't know. And the example here is if an exposure is less than 50% ideal, then you'll see a little bit of noise. So you can be off by approximately 50% too low, and the image would be mostly okay. The exposure can be over 200%, over 200% greater than it should be before you start to lose contrast. And so you can see here that if you underexpose just a little bit, you start to feel the pain, right? The noise creeps in a little quicker. But if you overexpose, you really, really have to overexpose that patient, turn that knob all the way up before you can visually see that you've overexposed the patient. And because of this, we tend to see what's called dose creep. In other words, No technologist wants to have the radiologist call them up and say, this image was bad. I cannot read it. Call the patient back, re-image it. No technologist wants to hear that. And so therefore, it's so much easier to say, we'll just make it a little hotter, just a little bit more radiation. Then I know the image will have no noise in it. We're okay. I won't get yelled at. The image quality will be sufficient for the radiologist. But over time, people tend to keep turning that knob up, keep increasing the image quality. And so what happens, because there isn't that physical cue like film, when you overexposed a patient in film, it ruined the image. And so because we don't have that visual cue, it can accidentally creep up over time. And this is the example I was trying to show you a moment ago. So when you look at film on your left, underexposed obviously was very white, overexposed was very black. And remember how we talked about when you look at the histogram, the exposure level would shift. If it's ideal, it'd be somewhere in the center. Underexposed, the histogram, the pixel values will be shifted left, more towards the white side. Or if it's overexposed, there'll be a lot more black pixels, dark pixels, and they'll be shifted to the right. And then, of course, the shape of that. Remember, the shape is always specific to the anatomy. But in digital, look at that. Underexposed. Now, you may be able to see from your screen that this is obviously noisy, right? It's a little less noisy. Excuse me, more noisy. This image, I would hope you would think that's a pretty good quality chest radiograph. And then this one right here, overexposed, I would think you would probably say, as a radiologist, I will still read that image. That image still looks pretty good. But the reality is this image right here, had it been imaged on film, would look horrible because you burned out the lungs. So we have to be able to figure out a way to optimize our images using, these dose metrics that we've talked about. And as Tanya asked, what can we use so that the end user, the technologist, and the radiologist know that they've acquired the image properly, the dose is correct, therefore the image quality will be appropriate. So we talked about error curve at the detector. We calibrate this, we establish this so we get proper auto exposure control, AEC control performance on each system. And then we talked about the incident error curve, which is the value that is more typical to a patient or a population, depending on how you're calculating it. These are the values we compare to published doses. We're going to compare it to the national DRLs that Thailand, for example, has built or measured and developed. We can use our CAP or our DAP, and then we have the EI and DI, which we're going to focus on. All right, so why worry about the radiation dose calculation to the detector? Well, we know, as I kind of verbally said this in the last talk, by the time the photons pass through the patient, pass through the grid, the table, the grid, to get to the detector, it is altogether very small. 1/100th of the entrance dose, 0.02 milligray at the exit, compared to, say, 2 milligray at the entrance skin level. So what we need to do is set up the proper dose to the detector, and you want to do this for all the X-ray units in your hospital. You need to make sure that if one patient goes into room 1, they're going to be exposed similar if they go into room 2, 3, etc. So what we need to do is calculate the dose per mass for all of our X-ray rooms. And we do this as a way to know that the auto exposure control is the same. Now, obviously, we want to know that the patients are getting the same radiation dose if they go from one room to the next. But in a bigger picture reason, we're doing this so that the image quality will be the same from room 1 to room 2 to room 3, etc. Here in the US, our standard is plus or minus 20%. So if you go in and you say you image under RQA 5 standards, so you have 6.8 millimeters of aluminum, half value layer, and you measure it at, say, 100 centimeters, source to 100 chamber distance of 100 centimeters, and you do, let's say, 25 mass, you'll get a value, a dose. I don't know, let's say it's 10. Well, let's just say it's 25 milligray. So 25 milligray divided by 25 mass is 1 milligray per mass. And now I go and do that exact same thing in the next room. And if it's within plus or minus 20%, I'm happy. Obviously, I'd like it to be better. And then I go to the next room, the next room, the next room. And if they're all basically that same ratio, I feel comfortable knowing that my systems are all performing at the same level. Therefore, the same size patient on every machine should get the same dose, and the image quality on every one of those machines should be the same. So now we're going to use the EI to verify that in real time, every time a patient is exposed, they're examined, they get their exam, and then the images show up in PACS. And Tanya and all her radiologist friends have talked to the PACS people, and now they see EI at the bottom corner somewhere on their screen, and they're going to look at that value. Now, like I said, EI is a great number, but EI for a C-spine is different than an EI of a chest, of a lateral skull, et cetera, et cetera, et cetera. So what we're going to do is we're going to actually calculate, we're going to use this value to calculate DI. I recommend this just because it's so much easier to remember. And I hope that all of your systems would allow you to do this. Definitely the newer systems. DI and EI, DI has been around for at least a decade now. EI has been around for longer. So at the minimum, I know all your systems will be able to show EI. In the best case scenario, they can show DI. But to get DI, the key here is the EI target. So we talked about quite extensively in the last talk how we make sure EI itself is accurate on the machine. So we're just assuming that's already done. We are assuming at this point it is accurate. So what is the target value per protocol? Most systems, especially the newer ones, they may already come with vendor-specific preloaded target EI values, or TEI. And the way you can do the way they do this typically is they'll just image a bunch of phantoms. They'll pick, oh, that one looks overly exposed. That one looks good. Okay, I like this value, so I know the EI of this value, and that becomes the target EI. Now, you can do the exact same thing using your own phantoms, and that would allow you to figure out if you like the target values that the vendor provides for you. Ultimately, the target value you select needs to make the radiologist happy. Some radiologists, for whatever reason, may want to see an image that looks a little bit more this way, or they may want to see it look a little more that way. And so you're going to work with your lead radiologist for all the various different areas, maybe your thorax people, your abdomen people, your MSK people. So it's going to take a little bit of work initially to set up your target EI values. And maybe if you don't have a lot of physics support and a lot of lead technologists, or your technologists don't have a lot of freedom to work on this with like a radiologist, then maybe your major academic centers have to do this. They establish it, and then they can share that with other local hospitals. And, a population, say in central Bangkok versus northern versus southern, your population distribution will be slightly different. But locally, hopefully it won't be too different. The variation won't be too bad. So the target EI at one hospital is probably going to be the same as the target EI at another. So you can do it individually for every hospital, or you can do it for, maybe like a region or a larger group of clinics. So this is an example of how I did it. Now, I would argue that it's basically the same here in the US as it is in Thailand, as it is in any other place in the world. That is, when you look at the exposure index distribution, then what you will see is, this is basically a Gaussian curve. It's got a kind of a normal distribution. There's obviously a central peak here. There's the mode. So the median is going to be somewhere in this region, right around here. And that value is, in this case, about 420, 450 EI value. Obviously, it's got some lows and we got some highs. Now, this is I talked to you about building that software. This is that software interface, that GUI. Here you can see the date December 16th. So let me just talk a little bit about what you see here to make my point. So what it does is the system loads all of the different machines. It loads all of the exams that were acquired on that machine. So obviously we do a lot of different looks in radiography. It actually even lists all the the users. And so I can run reports based on each user or technologist if I wanted to. Mostly I want to look at this as a function of exams. So in this case, I have PA lateral, chest, PA lateral listed. And when I run this report, it looks at and I can tell it what my upper limit. I will pass or fail based on a deviation index of +1 and -2. That's just a random number. You could pick a completely different number if you wanted. And then any patient exam that falls outside of that range will be listed here. Now, this is just how I do my quality control. I've obviously blacked out the patient MRNs. But the point I want to make here is this is old data, December 6, 2016, May 2017. Look at the peak here. This peak is basically 420. This peak, 420. So even though back in December of 2016, I had a larger skew of patients that got underexposed. And by May, as we worked with the technology to get everything a little bit better, you can see there was a lot better usage of the system, of this particular scanner. And there were very few patients that were under and very few that were overexposed based on my criteria. You can still see that the value in the center basically was the same. That is a very good candidate for a target EI. So I could use the value that the vendor gave me. In this particular vendor, they say a chest PA and lateral should be somewhere in the 400. In our case, when I worked with the radiologist and I got the image to look the way they wanted it by setting the KV and the MA and all of that, the auto exposure control, all of that, it actually turned out to be about 420. And so that was my target. And you can see how it's basically the same. Now, there is always a distribution. There's always going to be a variation. We're not always getting a value exactly at the target value, EI. But we want to get it within a range. And so that's how we can use it to calculate the DI. All right. Now, yeah, I explained that. So when we establish the target EI value, we have to obviously create it for all the different types of anatomy. And so you can run your reports, you will do you can use your dose software, your dose reporting software such as Radiometrics, and you can collect a report of all the chest protocols and the knee protocols and stuff and look at EI. Or if you don't have that software yet, you can simply just run reports. You can talk to your PACS people, and I'm sure they could run a report, because obviously they can look at all of the images in the PACS. They got hundreds of thousands of PACS, and they could probably run a report that looks at the DICOM header. And even if they didn't do all those crazy calculations I talked about previously, if they at least pulled the one number, the EI value, the EI value and the protocol, so if is it a knee, a head, or whatever, then you can start to create these types of histograms like I showed. So those are the two most important things: the EI value and the body part. So we set that up, and when you look at the distribution, you might see, well, there's the median or there's the mode right there at the dead center. And so 420. Now you go and you look at the images. You pull them up on PACS, and you get an example of 10, 20 patients that were all imaged with an EI of 420. And you look at them, you get a radiologist to look at them with you, and they say, yeah, I like this. I think this is good. Now you might also have them look at some that are a little lower, maybe a little higher, and they might say, this all looks fine. This all looks fine. So you just look at that distribution and say, okay, I'm going to start that value off as my target index, my target EI value. You do it for all the different protocols, and you create that TEI for Yeah. You create it for all of the protocols. But one thing that you kind of want to do is you want a higher level value. In other words, there's chest, right? You don't want to get too in the weeds. You can find a target in EI value for chest, but if you have a TEI for AP chest, for PA chest, for lateral chest, for supine chest, for decubitus, prone, I mean, you can if you want, but that's a lot of target values. And it gets to be more cumbersome to maintain all of those values. When it's all said and done with, remember, the histogram, when you acquire an image of the chest, the histogram will mostly look the same, almost always, for across all patient sizes, both genders. It's always going to have kind of basic same peaks and values. As it shifts left to right, that tells you if it's over or underexposed. Now, if the patient was prone, supine, standing, APPA, all of that, I mean, the histogram is going to look a little different. It might shift just a hair there, here and there, but for the most part, it's going to look the same. So, what I'm trying to say is, don't overdo it. A target index, a target EI value for chest, for maybe arms or legs or extremities in general, abdomen, pelvis, that's probably the high level that you need. And we use that to calculate DI. So setting up, now that we can calculate DI, the question was, as a radiologist, I'm looking at my screen and I'm being attentive. I'm awesome like Tanya. And I look at it and I says, ooh, I got a DI of 0. Well, I know DI of 0 is awesome. But what happens when I get a DI of 1, 2, 5, -4, 7? How do I understand that? So basically a decade ago, when we originally calculated and came up with the idea of DI, the physicists arbitrarily said ±3 is the threshold for good and bad. Everything above and below a DI of negative or +3 should have the image. You should reacquire the image. You should re-expose the patient. And what ended up happening was, from almost day one, people were imaging and they would see an EI value of 3, maybe 4. And they would look at the image and they say, this looks great. It looks fine. I see no reason to re-expose this. But yet I was just told if the DI is over 3, I should re-expose. And so from day one, everyone started to question those arbitrary limits. So in another group got together, and I was part of that group, and we looked at it for 2 or 3 years. And in 2018, we published our results. And basically, we looked at tens of thousands of exams across all of the US, and we wanted to know what the distribution of DI values was at all hospitals, or most hospitals, of course. And what you see here is just that result. DI all the way out to ±10. And what we also did is we took those images and we not all of them. No radiologist was signed on for that, but we looked at hundreds of images, thousands actually, not tens of thousands, but thousands of images. The radiologist looked at them and we did it for across all of the DI values. And then they basically scored them saying good, bad, or ugly. And what we found out was that basically within that ±10 DI, most of the time, the radiologists were okay with those images. The image quality looked fine. There wasn't really any clipping there, at the higher level. And even though it was a lot more noisy at a -10 DI versus a 2, it was still okay. They could still get what they needed for their calculation, for their read. So here you can just see some plots on the right-hand side, a couple of different, each hospital is denoted by a different letter. I don't remember which one was my hospital, but basically you can see here that the dashed lines were ±3. That was the original value that we said was good. Obviously 0 was perfect. And then what you see here is the bar, you have the whisker plots. So the median value is shown as the bar. And then you got the first quartile at the bottom of the box, third quartile, and then you got your minimums and your maximum. And just looking at this, just the overall spread of it, Besides Hospital E, Hospital E was the only one that had a median of actually no, Hospital F was the only one that was close to having a median value of 0. For everyone else, I mean, these guys, some of these median values were over the plus or minus 3, but yet that's how they were imaging every day. Now, would it be nice if we got everyone right down the middle? Probably. And using quality control techniques and maybe a small team of physicists, radiologists, technologists, and PACS people, your IT folks, we can work to kind of streamline that and try to get that all down the middle. But the point here is we found out that yes, you can actually image with a DI value that was greater than plus or minus 3. In fact, you could probably get even higher. So what we did in our publication is we recommended that you start looking for quality control problems after plus or minus 2 standard deviations from your mean. So obviously every hospital, as you can see here, has their own means and median values. And you know what the standard deviation 1 and second standard deviations are. So you can do this for your own hospital. Now, the image may not need to be reacquired, but the image should be flagged for review. And so if anything's over this once again, an arbitrary threshold of plus or minus 2 standard deviations, it's a place, just a recommendation, a place for you as a hospital to start looking at why that image was imaged, why that patient was imaged such that they were outside of plus or minus 2 standard deviations from your hospital's norm or median. So let me give you an example from my hospital. And what ended up happening is we were looking at our chest APPA. So this is that weird little hump that you saw in my patients. In we looked at intrinsic skin dose as a function of age. Well, this is a plot of, so the first here on the left is deviation index and frequency. So this is just a normal histogram plot. So the vast majority of my patients that were getting or undergoing an APPA, the vast majority had a DI of 1, which is pretty good. And then a little bit higher, 2, and then somewhere between 0 and 3. And that was basically my first standard deviation. 86% of my patients, or the patients at my hospital, fell within that plus or minus 3. I just use that as a common way to look at that. Not that I said that was the right or wrong way. That's just the way I looked at it. So most values that were outside of this range were for a very specific protocol, patients under 6 years. So now I plotted this data as a function of their age and the deviation index. So once again, this is just data that I can take from the DICOM header. I know what their age is. If the technologist types that in, or if the computer pulls down, the RIS system pulls down the patient's medical record and puts the age in for you, which they pretty much always do nowadays, you can make this plot just like I can make this plot. And here you can see, it's a scatter plot. So our older patients, and we don't do a lot of them because we're a pediatric center, but we do some. The vast majority of my patients, you can see here from 25 down to basically 6, right here. That was just a big clump of them all right there around deviation index of 1, which is this dashed line right here. And then here's my plus or minus 3, the solid red bars, vast majority. Now, there was always an outlier. There's always an outlier for everyone, right? Someone didn't get positioned right. Maybe someone has scoli, so they can't align properly. The system's going to calculate a weird DI if the patient just can't be positioned normal. And so abnormal patients will cause abnormal values, but that's okay. We look at some of these people, some of these exams, and you immediately see that they're contorted because they're maybe because of scoli, and you immediately go, okay, I know what's wrong with. Just move on. We know that the system can't do any better than that. Now, if it's a patient that got normal looking patient, but their lung fields got totally burned out because the technologist somehow did something weird and it's just a really high dose, well, then that's an education point where we can go back and try to educate. But in this case, you can see here when I looked at the data under 6, The preponderance of mine, I had a very large, so a lot of them were fine. But there was this chunk right here that were being overexposed, and there was this chunk down here. There's really teeny little young kids. They were getting way underexposed. So I knew I needed to go through the process of quality control on those. Now, I'm going to talk about that in a second. What do we do in the moment, though? Patient just got exposed. The technologist is sitting in their work area, the console area. They pulled the trigger and they looked at the display. If you have a system that will immediately display DI, that's a good thing. And I would highly recommend you turn that feature on, because then they can immediately ask themselves, is this good? Is this above or below my 2 standard deviations? Now, how do they know what that is? Unless they're great and they like to memorize numbers, they probably won't know. So you'll need to put a chart in their room, in the control booth. And that control booth will be for, chest, abdomen, pelvis, all of the major protocols with the target indices, target EI values. You will just simply say, this is my target. This is the acceptable DI range. This is less than 2 standard deviations, might be a DI of -8. And so they would look at their screen and say, oh, I got a -9. I am outside of that -2. What should I do? Well, this is kind of the workflow that at least we recommended. You don't necessarily have to do it, but we recommended this in our publication, where that person would talk to either their supervisor or the lead quality control technologist, if you have one. And they're going to just look at it. And if they feel it's diagnostic and it's acceptable, then they would just send the images to PACS, but then they would flag it, mark it down as something that they should review. If you have a monthly QI monthly group that gets together, or a quarterly, however you look at your rejected images, your rejected films, however you do that, you would just mark this and review it. Now, if the two of you have put your heads together and go, I don't know, it looks pretty noisy. If you're not sure, that's when you pick up the phone, and if your radiologists are okay with this, you would call them. The radiologist would then pull the image up in PACS. They'd make a very quick look at it and say, yeah, that's okay. And obviously they're going to push it off the side and they'll keep going, doing their own thing. And eventually that image will get pulled, that patient will get pulled up later for review. But if the radiologist says on first blush, it looks okay, then it goes to PACS and on, mark for QI. If they say, no, this doesn't look good, just initially, I don't really think I could read this, then obviously you would re-image the patient. And in a somewhat similar way, if the value was higher than 2 standard deviations, so it's assumed that it's the upper level, the upper standard deviation is 9. So the lower was -8 and the upper is, say, 9. And it's just written on a piece of paper in their control area. In this case, they call their supervisor again and they look at it. Now, over 2 standard deviations, it means it's going to be highly overexposed. So what you're looking for now is evidence of burnout and clipping saturation. If there is evidence of this, and if you try to reprocess it like we talked about last week, and you still see the clipping and saturation, then what you need to do is reacquire the image. But if you look at it and maybe there is, but when you change the lookup table, it kind of clears up and the grayscale still looks okay, then you can send it to PACS, obviously mark it for QI, and you review it later at a later time. And then always, if you are in doubt, consult a radiologist, etc. So the only real big difference here is if there is potential burnout, then you can maybe try to adjust it. All right, so that was the approach for setting up your EI targets and your DI. So how do you use that then for internal quality control? We talked about, it looks like, oh, forgive me. One of my slides it's either out of order or I accidentally deleted it. So I'm sorry. I meant to talk a little bit about the results of this. So hopefully that slide will pop back up. So if we see it again, we might have to do a small little detour. But moving on now to incident error karma. So this is the idea of setting up a value now that we can use for a diagnostic reference level. And so this is what you guys used in Thailand. You used actually not the incident error karma, you did the entrance surface error karma. So incident error karma, remember, does not include backscatter. The entrance surface error karma does include backscatter. And then if you took it one more step further and calculated the skin dose, you would need to add a couple more correction factors. So entrance error karma is the value that we're going to typically use to calculate our national DRLs. So how do we know that this is proper? What do we need to do to make sure this is properly calibrated? It's a good value that we're submitting so that the value can be averaged and then, of course, redistributed as a national DRL. First thing you need to do, just these are some generic pre-step optimizations, is you need to make sure there's a standardized KV for select exams. So chest exams, abdomen, pelvis, you just need to make sure that we have standardized KVs. This will allow you to compare these values between hospitals with similar equipment and protocols. In other words, try to set your techniques, your acquisition techniques, so that they're fairly similar, at least inside your hospital, but definitely regionally, that would be ideal because then the values are more the same across the board. Obviously, we need to calibrate the AEC system, as we talked about quite extensively. This allows for the MAS to be the same mostly for every body part. The KV is a value you have to change physically. You have to select that. But for all your AEC protocols, the system will select the MAS if it's properly calibrated. And then, of course, the third option the second option in all this, you let the system do it, or you used fixed techniques. So you can look up charts you can set or place lookup charts for mass and KV in the control booth, and then they just know to do this. We, for example, do something somewhat similar to this where we use patient size as a metric. So every patient that walks in the door, we use calipers. If they're doing, say, a lateral chest, we'll measure their lateral chest. If they're doing APPA, we'll measure, of course, their anterior posterior dimension. And then the system will have electronic charts where they just look at the size and they click on the value on the screen, and it automatically sets the right KV and it sets the right sensitivity and all that, so that we know that we'll get the right MAS on the output. So how do you set up these exposure charts, or how do you verify them? Well, we've talked quite a bit about using different types of phantoms. We talked about using plastic, these PMMA blocks. They're great. They're not patients, of course, but they're very adjustable. I can add a block or take away a block. So I can change the overall thickness of my quote unquote patient, so I can get a rough idea of how the technique factors will change with size. I already talked quite a bit in several talks ago. I gave you the breakdown of how you could set up an abdomen for a 5-year-old, a 25-year-old, etc. How many block thicknesses you would need. So I'm not going to go back over that. You can always go back to that talk. But the point here is using a phantom gives you the ability to really play with your techniques. Whereas obviously you can't do that with patients, and obviously you shouldn't do that. And if you have the anthropomorphic type phantoms, well, you just need a lot of them, and that can be very expensive. All right, so we talked about making those correction factors to entrance skin dose. And so we talked about doing this calculation by hand, or we can do it by, that technique I shared. And this was the slide I meant to show you a couple of slides ago. This idea that here you go, we see the age, the patient age as a function of deviation index. And you got your plus or minus 2 standard deviations, you got your plus or minus 3 DI, and then we got your mean. Now, if I take this data and I actually plot it a little bit differently, if I take and I plot it as a function of deviation index and entrance skin dose, because I have that that approach that I discussed last time. Here you can see that distribution of the lateral. That looks normal. There are, of course, some in cases where the patient being underexposed. But if you look at the AP and PA, that does not look like a normal distribution. There is this big chunk of patients that are being overexposed right here. And you can see the relative effect of it on their entrance skin dose. What would be a normal exposure, somewhere below 0.2 down to your typical less than 0.1, 0.07, etc., 0.05 for a normal chest. Here you can see this protocol was horribly overexposing our patients. And so by knowing that, I was able to go back through and make some corrections. So when you plotted it as a function of age and entrance exposure, so not deviation in entrance exposure, but age and entrance exposure, that's how I identified which protocol was not going properly, made the corrections, and then you can see this is what it's supposed to look like, at least for my hospital. We always put a little bit more dose on our teeniest, tiniest patient, and that is because they have the teeniest, tiniest anatomy. And we absolutely want to be able to see those teeny tiny structures. Unfortunately, you just need a little bit more radiation dose, but that's okay. So this little tail up, this little point that goes up a little higher, that's expected. But we don't have this weird hump right in the middle. My data is nice and monotonic now. It does increase, as it should, with size. And so by making that correction to that one protocol, now everything, now 95% of my patient exams are within DI of plus or minus 3. And, there's the patient doses. The point here I'm trying to make is all I have to do is tell my radiologist to think of a number, plus or minus 3, plus or minus 4, whatever it is that you establish as a normal range in your patients. And then that's all Tanya has to think. She doesn't have to think of an EI of 400 for chest, an EI of 300 for an arm, an EI of 200 for an abdomen. She just needs to know that it was within plus or minus 3. And then she then would obviously, with education, and the same for all radiologists, with education, they would understand if they get a DI that's a little higher, if they feel comfortable with their read, they do their read. But if it's over that number, maybe they flag it and they ask for the technologists and the physicists to review that as part of their QI process. Okay, so moving on, we talked about entrance skin dose. Skin is only one organ in our entire body. When it comes to fluoroscopy and radiography, it's basically the only organ that we calculate the dose for because it's the easiest one. When it comes to calculating all the other organ doses in our body, it's very difficult because in radiography, unlike CT, we're not actually imaging the whole circumference of the body. And, the field of view can be actually quite coned. And so you may only be getting part of the liver and only part of the heart. Or you might, if you're doing an abdomen, you might only get the bottom part of the heart, for example. The chest, of course, you only get the top part of the liver lobe, upper liver lobe. And so when it comes to actually calculating organ doses, it's not that big a deal in X-ray, in my personal opinion. And that's why you actually don't find many publications that talk about organ doses in X-ray or fluoroscopy. In fact, I was looking through a bunch of publications and I had to go back pretty far in 1998. This is a really good publication if you're ever interested in reading it, where they used Monte Carlo to simulate the dose to the various different organs. And then they came up with correction factors. And so if you know what the skin dose is, then you can correct for applying the different correction values, you can calculate the dose to all the different organs if you're interested in knowing that. And obviously, in this graph right here, I believe was for a chest, which was interesting because you look at the organ that probably got the highest dose is the adrenals. And that was just because, they're sitting right there on top of the kidneys and they're just right at the bottom of the field. At the bottom of the field, remember the Hill effect is the most exposed, the most penetrating. And it's got the greatest intensity of photons versus the upper part right here, where it's the best resolution. So therefore, the organs down here are getting a hair bit more radiation. And of course, adrenals are teeny, so they just dose as a function of mass. They get the most. Lungs, obviously, the next, because you're imaging the chest, the thorax, biggest organ in the whole compartment. Interestingly enough, you look at breast. Here we are, all the way down here. One of the lower dosed. You're thinking to yourself, well, for a female, breast anatomy can be a larger portion of the overall thorax. But because it's a PA, and that's typical setup for most chests, by the time you go from posterior to anterior to the point where you start exposing the breast anatomy, remember, we lose about 1/100th of the dose. We go from, say, a 0.2 milligray to a 0.2 milligray exposure on the output. So, or situating the patient as just kind of a classic example of being able to do dose sparing to relatively sensitive tissue. Breasts are relatively sensitive to radiation. And by doing a PA exposure, you are actually doing a very good job of reducing dose to that organ. So what are some rules of thumb? You can, if you want, come up with all these correction factors to calculate organ doses. I don't really think it's that necessary. But if you do know the skin dose, a good rule of thumb is that about every 4 to 5 centimeters deep into the body, you lose half of your photons. So you lose half your dose, roughly speaking. So if you know the dose to the skin, and we did one calculation as an example, let's say it's roughly 20 milligray. Well, you go down 4 centimeters or 5, now it's 10. Go down 4 or 5 more centimeters, now it's 5, 2.5, 1.25. You get the idea here. You're losing half of it every 4 to 5 centimeters. So you could start to do some approximations of the depth of these organs, and you can start to do averages. But what you see here is, let's take your liver as an example. The liver is going to take up a large part of that anterior to posterior geometry. Therefore, the part of the liver that's the closest to the entrance is going to get a lot, and the part at the bottom is going to get very little. And so you're taking some kind of average over that area, maybe the midpoint, can give you a rough estimate of what the liver dose is. But it's highly heterogeneous. So unless you really need to know what the abdomen doses are, I would say it's probably not worth your effort to go through and calculate it. The only time it's probably necessary to do some type of organ dose calculation, it would be more of a, do the fetus or conceptus depth. And so if you had, as an example, a pregnant patient that comes through and you want to know what the dose was to the fetus, well, conceptus depth dose is typically assumed to be 6 centimeters. Now I get it, that depends on the stage of pregnancy, depends on how big the mother is, etc. But in general, from the skin surface deep, we typically assume the fetus is roughly about 6 centimeters deep. Fetal dose to a lateral projection is assumed to be about 5% of entrance skin dose. Fetal dose from a chest x-ray, obviously you're imaging up here, your lower field of view margin is at the, basically the abdomen, the liver area. So you have 10, 20 centimeters before you get down to the pelvic area, down to the kind of the uterus area. So now the doses are only about 1 to 2% of entrance skin dose. And here you can just see some other values that I took from a publication. So really, in my opinion, fetal doses are probably one of the few ones that you need to do an actual true organ dose calculation, quote unquote organ. So how do we optimize the most common dose metrics in DR and CR? We talked about all of these. Oh, there we go. We talked about air kerma. We talked about auto exposure controls, incident air kermas, cap DAP. We talked about good ways to set up EI. We talked about how to set up your target EI. We talked about, of course, what it means to do a DI calculation and what are some numbers that you can establish, or at least an approach that you can use to establish DI values that you can then share with your radiologist, etc. So now let's talk about diagnostic reference levels. Diagnostic reference levels, of course, will give every imaging clinic a chance to optimize their system based on the national values. You don't necessarily have to go through all of these steps that we've talked about. If you don't have the physicist, if you don't have the capacity to do these calculations, you can at least rely upon the DRLs provided by the government, or by the national institutions, I should say. Now, what you need to do, so you got the TIE data, which I'm going to show in the next slide, and they've established it for what, these 7 protocols. And then for most DRLs, you're just going to pick your 7 most common or the most typical type protocol, and they're going to provide you some numbers. So you need to do basic effort to understand what your value is at that entrance surface air kerma. So you'll take your air kerma values, your incident air kerma values, and you'll need to do some very basic backscatter correction calculations for these groups. Now, maybe you don't have the software, maybe you don't even have the ion chambers. You'll have to figure out a way to get those values, or at least common values. But at least once you get those values, you can maybe look at a small sampling, 10, 20 patients in each of these categories, just to get a rough idea, which will be a way to compare yourself for the DRLs. Ideally, you'd want to be doing a lot more, 20, 50 per category if you're looking at it manually. And if you can do it by software, obviously you want to do hundreds of thousands. And what you'll do is you'll make all those corrections, as I mentioned, and you can now compare your values to the national DRLs that have been established in Thailand. So by now, you all know the DRL is the 75th percentile. It's the 3rd quartile. So you'll have your means and your median values that you can look at. But what you're hoping is that your values will fall underneath. Your median value will be less than this value, the P75 or the DRL. So if you have a chest PA, its median value is 0.3, then you're at or below the national DRL. So that's good. Maybe room for optimization, but hey, you're below the national DRL. If it's a little less, then you're doing fine. If it's a little more, then it's a potential goal for you to try to reduce the dose in that. And then you can go back to the various different approaches that we talked about on how to identify which protocols, if there are sub protocols that are maybe over performing. So we had already talked about this several weeks ago. I know this is something that is an active work, is an active project, where your film screen doses are actually quite lower, well, in some categories, than your digital doses, where the reality is digital doses really should be the lowest because they're the most flexible because of that linear response. You can actually go pretty low and still get really good image quality. And so I'm interested to see in the next version in the next couple of years, as you collect more data, to see if all of your quality control, your quality, your approach to review and to diagnose and to improve will make a significant change to these values here, and see that the film screen values will probably hold constant because you've been doing those for decades, but these values will probably come down. But overall, compared to the IAEA values, as you guys have listed here, you're doing great. In some categories, you're lower. Some categories, you're a little higher. But for the most part, I think you guys are really doing great. So my one comment to you as I was reviewing these numbers was, if you hand this data out to all of these hospitals, they need to understand how you calculated your entrance surface air kerma. So where did you do that? Now, you provided the typical size patient, 60 kilos, but what you probably need to also do is, what is that typical thickness? 30 centimeters? So that means when hospital A in northern Thailand, they have their chest PA, and they need to know what that incident air kerma value is multiplied by backscatter so they can calculate their ESAK. they need to know where to either make that measurement or to look that value up. And so it's probably going to be, 30 centimeters from the table or wall bucky, or so many centimeters from the source to some point in air. And so I don't, you may have already provided that value, but I just didn't see that in your table. So that's something that I would recommend, that as you send that out, that's a number, it's a value that they can use to baseline all their measurements from. So you need a distance from the source where the DRL entrance surface was calculated, or a distance from the table or the wall bucky, just a point so they can orient it. And it's going to be an average value, right? Because there's a lot of 60 kilo patients that might be bigger, and a lot that'll be less than that. But that's okay. It's just one value that they can make their calculations so that they can scale their numbers to compare them to the national DRL. All right, so I am over time. My apologies. So I will just, we've already talked about those summary topics quite a bit, so I'll just skip over that. So radiographic doses are inherently low. I think we've already discussed that, but they are the most common examination type. So we can do so much good by spending a little bit of effort trying to make sure we are consistent or consistently good at imaging and radiography. All right, well, thank you.
Thank you so much, Sam. And I think right now the Ministry of Public Health is on the second round for the survey on the DR and CR dose. After we have the first survey in 2017, so this is like this year they're planning for the CR and DR, if I remember correctly. Yeah. So I think there is one question from the chat box, and you already answered that. So the question is about the manufacturer exposure index. Should we use that one, or should we do our based on our populations? Because there is like a different target between adult and pediatric population. And I think we already answered that things that we can like have some our own exposure index.
I mean, obviously the best place to start is what you've got. So if it comes pre-populated on your system, that's great. You've got something to work with. And then as you then set out, I mean, you have to understand everything I've talked about setting up all of these quality control programs, they've taken me years and years to develop. And so it's not one of those things where you're going to go out and you're going to do every one of your protocols in a month. What you do is you start with like the top 7, kind of like Thailand has done. Maybe chest and abdomen are your 2 most common ones. And so you look at the EI values that are distributed in your system. You look at the target EI value that either the vendor provides you or maybe a regional hospital provides you. And then you start to ask yourself, looking at that number, say 420 for the chest, have your radiologist look at it. And if they like that, you're good. And then you just keep going with it. And you can make slight changes. And I think the one thing I probably should have put in my slides was, will these values always be the same? And the answer is no. Just like a DRL, with time, every time you do another survey for DRL, one would hope they are actually slowly changing, maybe decreasing. Eventually you might decrease to a point after 2 or 3 cycles and they just won't change again because you've just lowered the dose as low as it needs to go. But for the most part, people come and go. Radiologists aren't the same in every hospital. And so there may come a point where one radiologist leaves and a new one comes in, and that person says, I don't like the way this looks. So you have to be kind of flexible with how you set these target values up. But once you've established something that looks really good and it feels good for the group of radiologists, then you just run with that. And maybe every couple of years you revisit that and make sure everyone's still happy. Could we lower the dose? Do we keep the dose where it is? Are we missing anything, et cetera? And obviously new technology comes out. These machines are getting so much better at handling noise such that we could probably reduce our target EI a little bit compared to maybe 5 years ago. And the images will look perfectly fine. The noise won't have any more noise. And that just gives us the opportunity to be a little bit better when we image our patients.
You just answered the thing that I'm going to ask next, because my understanding is like when we start with the exposure index, it's like the first step. And then we do some processing or calculation to get the deviation index for the radiologist or end user to understand the image quality, to say that we need to bring the patient back to re-image or not. And then the next step on that part, we can do the dose adjustment, right? To maybe like a lower the radiation dose that we give to the patient. Is that correct? In terms of like a step?
And the one thing I would say to all of that is remember that it's not ever based on one patient. And so that's why we collect all of these. So if a patient specifically was imaged and they're lower than or above, as an example, the 2 standard deviation DI, you as a hospital have to decide if you're comfortable with 2 standard deviations or only 1 or something in between. Let's assume 2 for now. If the value falls outside of that, in that moment, you make sure the images are sufficient for the radiologist. If they are, the patient goes away, the radiologist does their read and they write their report or they dictate their report. And then that patient gets listed and gets put in a bucket that we will review. And we keep collecting in this bucket. And at some point, monthly, quarterly, annually, whatever we do, we look at all of them. And if we see that there's a trend, this particular protocol is consistently having issues, then we fix that protocol. If it's just 1 patient or 2 patients, like I said, there's always going to be just something weird, right? The patient that can't position properly, or maybe the radiologist was just having a bad day and didn't like that noise, right?
Yes.
Radiologists never have bad days, right? And so if it's only just 1 or 2 patients, we don't want to go and change protocols based on just a small sample. And that's why we do need to collect this and over time review it. And when you get a sufficiently large population of issues, then yes, change.
Yeah. And right now for the DI deviation index, you recommend plus and minus 3, or can we go up to plus and minus 10 when we look on that things?
Historically, it was plus or minus 3. But what we found out was that +4, +5 was still okay. We found it was generally okay all the way out to 10, plus or minus 10.
Okay.
But that's why what we say is because it really depends on the radiologist. It really depends on your hospital. And so look at your distribution. And then I would say look at 1 standard deviation, look at 2 standard deviations. As a publication, just as a group of scientists, we got together and said 2 plus or minus 2 standard deviations is actually a pretty big jump. That's all the way out there at the 8, 9, 10 DEI value. And so we should probably start to look at images and start to ask ourselves, why are we so far away from the median? But if you set whatever you set your value at, just know that the value, that the image itself is probably going to be okay. Like I said, plus or minus 10, we were seeing it was okay. It really was. They're digital. Obviously if it's film, it's not going to be it's completely different thing. But if it's digital, the images are going to be pretty much okay. So start, if you want, just tomorrow, you can start thinking plus or minus 5, just if you want to pick that number. And then you start to realize, I'm collecting a lot of I'm getting a lot of images in my QI pile. And then you review them the first month or the first quarter, and you realize, like all of those were okay. So then maybe you can say, let's move that out a little bit. Let's make that plus or minus 7. And then you start to realize now there's fewer and fewer. Because remember, 1 standard deviation is 67% of your population, right?
Yes.
2 standard deviations is 95%. So what you're saying is at 2 standard deviations, 95% of the people that walk through your hospital, the images will never be flagged for quality control. Never. The radiologist will never call the technologist will never call the radiologist, and hopefully the radiologist will never get upset. And so, but we're talking about maybe 5%. And that's the whole reason we chose the 2 standard deviation. We figure 5% of a hospital that does, let's say they do 100,000 patients a year, right? So what is that? That's 5,000 patients a year that you would have to review. That's kind of a lot, actually, if you think about it. So you probably don't want to set yours too tight of a value, if that makes sense.
That makes sense.
Yeah, that's the reason why we chose 2 standard deviations.
That makes sense. And I'm going to start looking on that DI number when I read the study from Monday. So
Yeah.
thank you for telling me that. Yeah, at least it's a good practice for me.
Yeah. And just looking at that, and you may, as a radiologist, calibrate yourself depending on how many plain films you read a day. But you might start to realize, oh, wait a minute, that's plus or minus three, plus or minus three. I'm starting to think I don't like plus or minus three. And that just might be for you. And then you can start to talk with your overall QI group and say, hey, I just noticed, and it's going to take a while because you're not probably looking always the same chest radiographs. You're going to look at knees, arms, legs. I don't know. You might look at a variety. But my point here, well, obviously you're looking at the head, but but my point here is unless you're consistently seeing the same, if you're consistently seeing the same, then you as a user will probably start to realize what your preference is. Now, you're one person, so you have to work with the group, but being able to say, bring attention to this, like, hey, I feel awkward. There's something not right about the DI value for this lateral head that's roughly around a negative DI of 4. And then that's a way for the group to go back and start looking at it too. So 2 different ways. Radiologists can come and talk to them, or they will go to the radiologist and say, hey, can you look at these images?
Agreed. Yeah. So next one is, to my understanding, the DI can be effective indicator for QC QA in case that the TEI is optimal.
Yes. Right? And yes, she's right on the nose on this. If your target values are not appropriate, I mean, what does DI mean? DI is just the ratio of the value for the protocol for the patient in that moment to the target. So if your target of the chest, now I showed you my value, it was about 420. And if you, for whatever reason, actually set it at 200, well, that means the vast majority of your images are going to have a really high DI number. They're all going to be, 7, 8, 9. And when you look at your histogram of DI, it's going to be highly skewed to the high end. And you'll be like, okay, something doesn't look right. So when you just do your statistics and you look at a nice Gaussian, if you see a nice Gaussian curve, then you probably know the value right in the middle is okay, or it's a good place to start. But if you look at your distribution and it's highly skewed to one way, one left or right, then you've probably not set the right target value, if that makes sense.
I see. Yep. Okay, so that makes sense. And the last comment is about if we pay more attention to the TEI, because the TEI is reflects the deviation index. So which means we need to pay attention on those things.
So yeah, definitely as a physicist talking to other physicists, that's the number that I can change that makes the biggest difference, obviously, right? So I know that my detector dose to the detector is appropriate because I do that calculation. And I know that my EI value is correct because I do that calculation. Then the next thing I can do is make sure my target EI is correct, because then my DI calculations are accurate. So those are the 3 things I do as a physicist every year. I'm constantly just double checking those.
Yep. Okay, so thank you so much, Sam, for teaching us a very practical things to understand the physics, and we can apply it in our daily practice. And you can teach me to start looking on the physics number and things and pay more attention on those things. So thank you so much for always giving us excellent lectures.
And well, thank you.
And as usual, so after these lectures, we're going to send a link for evaluation, and please complete the evaluation by Thursday midnight. So Friday, you will get the CME certificates, and on Friday, you will get the link for the next week lectures. And next 2 weeks, we're almost done. We have 3 more weeks to go. So next 2 weeks, we are going to talk about the mammogram. And on the last week, we're going to talk about the it's like a wrap-up session. So if anyone has any questions, particular questions that you want Dr. Brady to comment, so please send us an email, or you can also put it in the evaluation form on what questions or what else you want. We want Sam to explain or give more detail on that part. Because right now we have one questions about the gonad shields in children. Do we still need to do it or not? So maybe we can put that things on the last session, like for maybe like the basic stuff, like for the gonad shield or thyroid shields in children, should we still do that thing or not?
Since that was actually specific to radiography, if you want, I can address that next week. I could talk for maybe 10 minutes about that and tell you kind of, how we do it and what are the rationale of using it or not using it.
Yeah, because in the past we always put a gonad shield in every patient, but right now seems like we don't need to do that anymore, but we still do it just like in case or something. So what is like a rationale behind those things?
Sure.
Mm-hmm. Yep.
I will talk about that first thing next week.
Okay, sure. Thank you so much, Sam. And we will see you again next week.
All right. Thank you.
Yeah, thank you. สวัสดีค่ะ So thank you so much. And we also want to thank our sponsor, Bayer, Philips, and GE to support this educational course. Thank you so much and see everyone next week. Thank you. Bye-bye.